Good afternoon, everyone. My name is Olivia Hunty from the New England QIN-QIO, and thanks for joining us for today's webinar, Session 3, Interact Webinar, Medication Reconciliation Tool with Sheila Eckenrode and Florence Johnson. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation, and we'll take questions at the end, and I'll provide you instructions on how to unmute your line. I'm going to pass this over to Sheila now so she can introduce our speaker, Margie. Sheila?
Good afternoon, Interact Pioneers. Thank you for joining us, and we're happy you're here. Today we're going to talk about the medication reconciliation process, a process integral to ensuring patient safety and smooth transitions between providers for our residents. Today's session objectives include understanding the medication reconciliation process. For me, it includes being able to pronounce that word, understanding how to use the medication reconciliation tool currently in the QIN system, develop a plan of implementation for this process and tool, and that's probably the most challenging thing we'll be asking you to do in this series, because for many people this is going to be a brand new process, and it's going to, at least initially, feel rather time-consuming and a bit complex. And then we'll finish up with a group discussion and review of the past 2 months' homework, because we haven't touched base on our homework in a while. So let's begin with a polling question. I'm going to ask you to respond to this question. Do you have a medication reconciliation process in place in your facility currently?
And we'll go ahead and ask Jennifer from WebEx to open up that polling question for us. Jennifer, when you're ready. Oh, perfect. Thank you. Please make sure to press submit after you have selected your question. That way we can ensure that everyone's questions will be counted, answers will be counted.
Are those to be tallied?
Unfortunately, if everyone does not press submit, it takes about another 30 seconds for the answers to come through. So they should be coming through momentarily. There you go.
Thank you. And for your response. Okay, so it looks like a fair number of people have a process in place, and I congratulate you on that, because when you're admitting a resident from the hospital, I know that this can be a complex and somewhat time-consuming step that's so important for patient safety, and I'm sure people anecdotally have stories of medication mismatches that they caught that could have resulted in true resident harm. I hear those all the time when I'm out in the field. Okay, so without further ado, I'm going to introduce our speaker, Margie Giuliano. She is the Executive Vice President of the Connecticut Pharmacists Association. She's a seasoned leader in the pharmacy community, is President of the Connecticut Pharmacists Association, and as President of the National Alliance of State Pharmacy Associations. She has served on various state and national health task forces and has participated in demonstration and research projects involving women's heart disease, smoking cessation, and most recently projects in medication therapy management. We are fortunate that currently Margie is contracted with Qualidigm and the New England QIN-QIO to improve medication safety and reduce adverse drug events and transitions of care. Welcome, Margie.
Well, thank you, Sheila. Good afternoon, everyone, and thanks so much for the opportunity to present today. As you are all well aware, I'm sure, medications are great when everything is going well, but they can cause many problems for patients if they experience an adverse drug event. Oftentimes, we see problems as patients are transitioning from one care setting to another. One of the key learnings we've seen is that med reconciliation, if done well, can help to minimize impact on our patients. Our objectives for today include defining the medication reconciliation process, identifying key healthcare team members to complete the MedRec process, list the components of the med reconciliation process, and apply the process in your specific environment. A troubling picture for sure. These statistics speak for themselves. 70% of all admissions to long-term care have at least one medication discrepancy, and up to 50% of discharge summaries and transfer forms contain discrepancies, and there is greater than 21% error rate during a handoff between the hospital and the long-term care facility. So I think there are lots of opportunities to improve. In 2014, the Improving Medicare Post-Acute Care Transformation Act, or the IMPACT Act, was passed. The focus of this act was to ensure that all pertinent health information is accurately communicated to the patient, the caregiver, and providers during transition. Medications are a big part of that pertinent information, and how it is transferred can readily impact patient safety. When we talk about medication safety, a primary focus is on preventing medication errors, but it does go beyond just the errors. We have to be vigilant about ensuring that what is being prescribed is appropriate, such as the right drug for the right diagnosis. And we have to review the patient's medication profile to identify any medication-related problems or discrepancies and then work to resolve them. These classes of drugs have been identified as most problematic. And of course, most of the patients that you care for are on this medication. So there's really a lot to balance. The Department of Health and Human Services has developed a national action plan to improve medication safety and decrease adverse drug events. In their action plan, anticoagulants, diabetes meds, and opioids were identified as high risk. And patients that are on these meds are more apt to be readmitted to the hospital and to be sent to the ER. So there needs to be additional focus when we see patients on these meds. We also have to be aware of the drugs on the DEARS list, since they certainly impact your patient population. And there's been a lot of work around antipsychotics and gradual dose reduction. This continues to see the need to really emphasizes the need to do a good evaluation when we're looking at patients' medications. The medication safety plan and measure in long-term care study focuses on the drug regimen review. Ideally, this review occurs upon admission, while the patient is in your care, and again upon discharge. The drug regimen review includes medication reconciliation, identifying and addressing clinically significant medication issues, and then following up on these issues. One of the concerns that we have identified in the medication safety work is that medication reconciliation means different things to different people. There needs to be a standard process in place so that when a med reconciliation is done, the expectation as to what has occurred is understood by everyone on the team. So how do we define medication reconciliation? The Joint Commission is an independent, not-for-profit organization that accredits and certifies healthcare organizations and programs in the United States. Accreditation is achieved when the organization has demonstrated meeting the performance standards for quality. They define medication reconciliation as the process of comparing a patient's medication orders to all of the medications that the patient has been taking. This reconciliation is done to avoid medication errors such as omissions, duplications, dosing errors, or drug interactions. It should be done at every transition of care in which new medications are ordered or existing orders are rewritten. Transitions in care include changes in setting, service, practitioner, or level of care. The goal is to provide an accurate list of medications at a given point in time, but we all need to use the same definition and standardize the process to be successful. So why is medication reconciliation important? Quite simply because the first step in the defense against medication errors at transitions of care is an accurate medication list. No comparisons or decisions can be made about medications if a starting medication list is not available. The goal of medication reconciliation is to ensure safe, high-quality care during the high-risk periods of care transition. Medication reconciliation has become a standard for safety and quality of patient care, yet it is still not established as an efficient and effective standard of practice everywhere. The medication reconciliation process includes 3 steps. Verification, which is taking of the best possible medication history. Clarification, ensuring appropriateness of medications. And reconciliation. It is important enough to reiterate that we should all be doing these steps in a standardized manner to ensure that when we talk about doing a MedRec, we are all doing the same thing and there is an expectation of what has occurred. It is not about the tool you use to document, but it is all about the process. Verification, or taking the best possible med history, is the most important step. The rest of the process is useless if the initial information gathered is incorrect. If the initial information gathered is incorrect, then the outcome of the rest of the medication reconciliation process will be faulty. This is because assessments of medication needs are based on the best possible medication history. The other steps involved with MedRec include clarification and reconciliation. The Society of Hospital Medicine defines the best possible medication history as the most accurate list of medications the patient should be taking and the list of medications the patient is actually taking prior to admission. It is called a best possible med history and not a current med list because it reflects the most accurate list of medications that the person is taking at this moment in time. This may not be the same as how the medication was prescribed. Medication lists are fluid. They can change frequently. The best possible medication history can be thought of as a snapshot, a sample in time of what the patient is taking for medication. In some organizations, this is referred to as a patient's home medication list. The list above includes different sources available to gather the information. Best practices state that at least 2 sources should be used to obtain the best possible medication history. Of course, interviewing the patient is not always a possibility, but it is a good source if you can do that. You can also always reach out to the family members as well. The community pharmacy is a great resource because they can provide a lot of information for you. You should use as many sources available to you to complete the actual list. The best possible med history is not just a list of drug names. Each medication on the list should include the drug name, the strength, the dosage form, the dose taken by the patient, the route of administration, and the frequency of use. The duration of therapy, meaning how long a patient has been taking the medication, is important to include, especially for antibiotics, to help ensure completion of the appropriate therapy. It's also good to identify when the last dose was taken or administered for each medication, especially during transitions. Remember that the list we take is not just for prescription medications. We also need to include over-the-counter meds, herbal products, and dietary supplements that the patient may be taking as well. The next step is clarification. The key goal of clarification is to identify potentially serious drug-related problems. This step should be performed by a clinician, preferably a pharmacist or member of the pharmacy team. Some of the drug-related problems are listed on this slide. We have to look and see, are there discrepancies in what was collected? Medication discrepancies are defined as differences in a medication list and what the patient is actually taking. So the dose could be different. This will be definitely a reason to get as many sources of information as possible. It's also important to look for the appropriateness of the medication. Is it appropriate for the diagnosis associated with it? Is it appropriate for the patient? Certain medications should not be used in the elderly. It's important to check for drug interactions since they can potentially cause harm to the patient. Have we documented allergies? Therapeutic duplication is also a common drug-related problem. This is where two or more medications are from the same chemical family or therapeutic class. It's important to identify these drug-related problems to ensure patient safety and the completion of an accurate medication reconciliation. And the next step is reconciliation. Any discrepancies, drug interactions, therapeutic duplications, or questions of appropriateness must be brought to the attention of the prescriber. This may be in writing, either on paper or in the computer system used to record the MedRec process and orders, or alternatively, this could be done by way of a verbal handoff to the prescriber. Based on their education and skill set, the pharmacy team should be the responsible healthcare members to perform medication reconciliation. They can most efficiently identify drug-related problems and provide recommendations to the prescriber based on clinical guidelines. When we want to build an efficient process, pharmacists should be part of that process. Then the prescriber reconciles the best possible medication history with the orders or prescriptions being prescribed for the patient. This is all done in an effort to ensure safety and quality across the continuum of patient care during the high-risk time of care transition. Transmission is an important final step for continuing this iterative process at each transfer in patient care. Transmission is the documentation of the reconciled list in some way so that it is available at future transfers of care for consideration. The reconciled list should always be communicated to the next level of patient care and to the subsequent member of the healthcare team. This includes when the patient is transitioning into a long-term care facility or upon discharge from a long-term care facility to home. Communication is key, and oftentimes this is where the system fails. The list that you hand off to the next care setting is the starting point for that group to do their own med reconciliation process, be it to the home health care agency or even, quite frankly, to the community pharmacy, so they can review and have for reference, and then they can confirm any changes with the primary care provider. So now we're going to take a look at documentation. Again, I want to emphasize that it's the process that counts, not necessarily the tool used to document, but you do need to document what you're doing. So this is the form that appears in the Interact system. As you can see, it has a place to document most of the pertinent information that should be documented in the standard process. They kind of combine the strength, dose, and dosage form. I would advise that each practice determine the place that this information goes. You may want to develop a protocol, again, so that there's standardization within your own system. As you can see in this example, there's not always a place to indicate dosage form, etc. Again, this form can certainly be adapted to include all of the pertinent information that we discussed earlier about, drug name, strength, dose, dosage form, etc. So as you can see, there's a place for a patient name. Again, the bulk of the information for the medication information, again, is here. I like the fact that they identify the source of the information. Again, you can see where they've been able to use 3 sources versus 2 sources versus 1 source. So best practices do look to have us use at least 2 sources of information. I like also that they provide a place for healthcare proxy contact and primary contact information, as well as a spot for the physician and the preferred pharmacy that the patient is using. So there's a lot of good information on this. Again, just to re-emphasize the fact that you want to make sure you get all the elements of the best possible med history recorded. There's plenty of space in here to do that. You just have to come up with your process as to where your facility is going to place that information on this form. On this slide, we see the pre-hospital medication list is identified, as well as the discharge home medication list. So these are the two sources that they've used to develop or verify this best possible medication history. So you can see when we're looking at the pre-hospital medication list that Chloricon 20 milliequivalents has been discontinued, and it's been replaced in the discharge home list with K-Tab. Also of note is that the Chloricon and potassium chloride both appear in the pre-hospital medication list. And that's why it's so important to collect information from all available sources and interview the patient if possible to find out what is going on. Remember, again, the community pharmacy is a great resource, so documenting that information in the form and getting that contact information, you can always reach out to the community pharmacy for additional information. So in clarification, we want to make sure that we review for the appropriateness of the medications with the diagnosis, that we note any medication discrepancies, dose discrepancies, therapeutic duplication, etc. We can see here where they have the list of drugs, and also that we've identified Senna listed twice in this chart. So that is definitely something that needs to be clarified. There's two different dosing instructions, and if you look further over, you can see that the prescriber has actually discontinued the daily dose, and looks like that would be the dose that is as needed for use. But again, that's a point that you're going to want to clarify before you do your final documentation and reconciliation. Remember, Chloricon 20 milliequivalents was discontinued in the hospital, but I don't see where we have the K-Tab documented in here, so that too needs to be clarified and resolved. All changes need to be documented in the system and resolved, and really make sure that we're ready also to be able to share that to the next for the next clarification. So reconciliation is also important. That's our third step.
Thank you.
So making sure that this is all documented in the physician's orders and in the MAR as well is important. So again, step one, we've got verification, collecting all the information that we can from all available sources to actually create the best possible med history. Step two, clarification, reviewing diagnosis, monitoring allergies, and then noting discrepancies, therapy questions, and clarifying any corrections that we have or modifications with the provider. And then step three is reconciliation. After discussing and findings, our new findings or discrepancies with in the medications with the provider to document any changes to the physician's orders and in the MAR. So although provision of medication reconciliation is a valuable service that facilitates safety and quality care, there are several barriers to its successful integration at all interfaces of care in the healthcare system. So I just want to review some of these barriers. First, there's a lack of ownership of the task. If no one is specifically responsible for the task of medication reconciliation, then this task can easily be viewed as added work, with no one profession or individual taking ownership for completing it. MedRec can be overlooked in this circumstance. So one of the key steps to implementation is to identifying the clinician who is responsible for the task. As mentioned earlier, the pharmacy team would be an appropriate person to look to take ownership. But duties can also be split. A clinician doesn't necessarily have to be the one gathering the information to develop the best possible medication history. If proper training is done of an identified staff member, they too can do the gathering of the information according to that standardized process. It's also important to remember what the goal of MedRec is. And it's really to create the most accurate med list possible to ensure appropriate and safe transition from one care setting to another. So communication is key, handoff is critical. Just because med reconciliation should be a standard at each transition of care in all of healthcare, there is no standard process for implementing this, and best practice standards, quite frankly, are lacking. So Qualidyne with the New England QIN-QIO has actually developed learning modules for med reconciliation that are an attempt to standardize the process and facilitate implementation. We've learned that many people have a different interpretation of what medication reconciliation is. By defining and standardizing the process, the outcomes and the expectations from a med reconciliation should be understood. Another challenge is technology and the lack of systems being able to talk to each other and share information. For example, is there access to lab values electronically that the team can use to see whether or not the patient's INR is in target range? Until systems can really talk to each other, this is going to continue to be a challenge. And finally, what I think is probably the most challenging barrier to consistently completing a thorough med reconciliation is time. Taking a complete medication history, comparing information sources, clarifying issues, and comparing the list to current needs at the transition of care is a time-consuming process. To do this right, someone needs to take ownership of this process and dedicate the necessary time required to get it done. In the end, it saves the healthcare system dollars, but most importantly, it creates a safer environment for our patients. So with that, I will open the floor up to questions.
Okay, so thank you all so much, and thank you, Margie, for such a fantastic presentation. Sheila, would you like to do questions at the moment, or did you want to do this?
Would be good.
Okay.
So feel free to ask any questions.
So if you would like to ask a question, you can press #6 on your phone to unmute your line, or you can pose a question in the chat box. Just make sure that you are sending to all participants. So again, #6 to unmute your line, or you can pose a question in the chat box. And just make sure to send it to all participants.
We're waiting for questions. Maybe we can talk a little bit about what the learning modules that we have for the MedRec process are, and where we house them.
I would very much like to talk about that, Margie. As Margie mentioned, we've developed 3 modules. They're about 45 minutes each that are available on the New England QIN-QIO website. I'll be sending out the link to everyone, all the participants after this. These are self-paced modules. One of the benefits, or one of the many benefits of encouraging your staff to take them is that there is a certificate of completion that we in turn can give to you and to your staff members after they've completed or successfully completed the modules and taken a post-test. This in turn allows your staff development people to provide some documentation to DPH or JCO if you're JCO certified that your staff has been formally trained in this process. So it kind of takes some of the burden of training off of your facility, off your busy staff development folks, and and also the burden of tracking, because we can in turn provide you with quarterly or annual reports of who at your facility has completed this. So we encourage you to use them. They're easy to access and, as I said, completely self-paced, so folks can do it at their own convenience. And I will send out that link to all the registrants today.
Another thing with those modules is that they do have a couple of tools that are available at the end of each of the modules, so that it helps with the implementation phase of getting MedRec into your system. So just to let you know, that's available as well.
It looks like we do have a question from Ashley. Does CCC or any other EHR have this integrated into the system? Marty, do you pursue that?
I don't know the answer to that, but one of the participants in this webinar might. Does anyone have PCC, their total package for all the Interact tools?
You could help us out with pound 6 to unmute your line. If not.
Ashley, I'll get back to you on that.
I mean, I know that some of the electronic health systems do now incorporate, the medication list into their systems, so it's starting to emerge, but, it still has a long way to go. I think, again, that's one of the challenges that we've seen with MedRec is the ability for systems to talk to each other and to transmit that medication list and across care settings.
But that certainly would be convenient if there was some way to upload the W-10 into that tool, so then you would only have to do the review. I'll check on that for you, Ashley. Before we go, Margie, I was wondering if you could speak a little bit about Margie works in care transitions, and she's always looking at medication safety, and we are measuring adverse drug events across the state. And there's some interesting information about ED visits and readmissions and what percentage of them involve some sort of adverse drug event.
Sure. I mean, as I mentioned earlier in the slide, the three primary categories of drugs that are really responsible for the majority of adverse drug events are the anticoagulants, the diabetes meds, and the opioids. And, looking at the data that's shared to us by CMS, we can really see the trends that are going on with the admission rates and hospital utilization rates, not always even due to an adverse drug event, but primarily for the patients that are taking these medications. They tend to be more of the patients that are using the ED or being hospitalized. So we're looking at opportunities to try and address these issues and minimize hospital utilization. Obviously, in the long-term care world, hospitalizations or rehospitalizations after patients are sent to you is going to impact your viability, shall we say, as well from a payment perspective. So looking at what we can do together to address these issues is certainly one of the key things that we look at. Talking about the MedRec process, we're trying to look at ways that we can help implement this for facilities. Engaging the consultant pharmacists that you have contracted with you, potentially working out a process where we might bring in some pharmacy students to help with that. These are all opportunities that we could look at, with the facilities to help in documenting and providing data that will help to track some of your own admissions or readmissions. So there's a lot going on in the med safety world, and it'd be great to partner with some of the long-term care facilities to look at adverse drug events and how your patient population is impacted, what your readmission rate is from your facility. Is it due to drugs? How we can work together to look at that information. So certainly in the med safety world, we're looking for any opportunities to partner and to help you implement some, interventions that could impact that.
Thank you, Margie, and we're interested in your opinions and your experiences, so please reach out to us if you have ideas on medication, reconciliation, adverse drug events, and how they contribute to readmissions in your facilities. If you are thinking of implementing anything to increase medication safety, whether it's a certain protocol for reporting INRs, whether I know some facilities are moving towards eliminating anything to do with an insulin sliding scale because of the dangers there. So if you want to pilot some of these initiatives, please reach out to us because we're very interested in that. We're very interested in looking at how adverse drug events affect readmissions. We have received some data from claims from the National Coordinating Center that indicates up to 30% of patients who arrive in the emergency department have some medication adverse effect involved in that visit. So that's big. That's a big chunk of our readmissions. So do think of that. But thank you again, Margie, for your excellent presentation.
Thank you, Sheila, for inviting me, and I welcome questions.
Again, pound 6 to unmute your phone line. If you would like to ask a question, or if you want to ask a question in chat, you can go ahead. We'll give it just like 30 more seconds, and then I know Sheila wants to continue on. So we'll let Margie just sit in anticipation for the next. All right.
Okay. Well, thank you again, Margie. And please, as I said before, reach out via email, give us a phone call. If you have ideas about improving medication safety at your facility, if there's something you're interested in piloting, if there's something you want to share. So usually we use the last part of these webinars to go over homework, if you remember that, and we haven't done that in a couple of months. So I'm going to just review what was asked of our participants in the last 2 months. And hopefully I can hear from you folks on what's going well and what isn't. So if you remember from way back when we had session 1, which was back then in March when the weather was wet and cold. Oh no, that's now too. So anyway, it was a different month. We had asked you to develop a team or use an existing team within your facility that looks at aggregated data, that works on quality projects. At the first meeting of that team, or if you're using an existing team, as part of the agenda of that team, was to go to the Interact website, which of course is integral to implementing Interact. You've got to know where these tools live. And also present the project to leadership, and specifically your medical director, your APRN, the folks that you rely on for clinical leadership, and let them know that this is a new initiative, and talk about it with your staff. So I'm going to ask you to share, any experience you had, what kind of team you developed, if it's a new team, did you use the existing team, and please, if you can give us some feedback, it's important because with each new facility implementing Interact, the most valuable information they get is from somebody who's already done it successfully. So, anyone want to chime in? Is anyone using an existing team?
Again, pound 6 to unmute your line, or if you'd like to just write it in the chat, you can as well. I do want to let everyone know that we do have the attendee list up, and Sheila may be calling people out, so we'll see.
Hi, this is Janice at the Lutheran Home. How are you?
Good, Sid.
Hi, Janice, how are you?
Good. So I decided to put the Interact into our currently existing quality assurance meeting that I have. So all the team members, the department heads are there. There's representation from CNA. So that's worked out well. After we had our first meeting, which was in March, my meeting for my quality assurance meeting came very soon after that. So I put it into the existing meeting. Also, we had a medical staff meeting in April, so it was a time to discuss it with the physicians. I had already talked as a sidebar with the medical director, who obviously was very much on board with the Interact tools and wanting to, disseminate those tools into our facility. And then my director of nursing has taken it into her staff meetings, her nursing and her CNA meetings, to disseminate it even more. So it's kind of a multi-pronged approach to getting the Interact, word out that we're part of the initiative, part of doing the webinars every month, for the rest of the year, and what that will mean for the facility. So that's kind of what we did.
That sounds like a great plan. I'm curious, has your medical director heard of Interact previously to your introducing it?
Yes, she had. Yes, she was familiar with the Interact. And then we have, obviously, the hospitals that we associate with as primary provider network to 3 hospitals in the area. They speak of, obviously, the Interact tools as well. And she's particularly associated with one of the hospitals, so she was excited about it.
Oh, good, so she's heard the buzz. That's a great plan, and I have heard that in other Interact webinars that, it's kind of like finding the path of least resistance. You've got a group that already meets. It can be more time efficient than forming a new group.
Yeah, so I included it into the agenda for that first, for March. And so that's what I'm doing every time I meet as a quality assurance. I have the Interact as part of it. So it's kind of interesting because as we go through each month, we have a different theme. So I discuss that with the staff and that, so they're kept abreast of what's going on.
That's a great plan. Thanks for sharing that.
You're welcome.
Presenting next time. We'll have you on the agenda next Interact webinar series. We're looking for someone to pass the baton to, Janice. Anyone on the call form a unique team just for Interact? Okay, so I guess no one took that path. But by now, hopefully, you've got some team, some group together to help you look at this. I think one of the missteps that we've seen in the past is the DNS, who surely has nothing more important to do or nothing else to do, will take this task on as well, and that can be overwhelming. This is a process and a program that needs to be disseminated through all levels of staff, as Janice was describing. So that's too much to ask any one person to do. So when you have a group where you have people like department heads that can bring it back to their individual departments, you've got some CNAs that can, talk to the other frontline staff, that's very helpful. Okay, so hopefully you've got that in place. And then we also had homework in session 2, and this usually causes a little bit of a buzz. What we asked you to do last time was to go to the NNHQI website to see if you were registered, and this usually results in people saying, I can't get on because the DNS 2 years ago had a password and it won't allow me on, so that can be a bit of a kerfuffle. So I want to hear if anyone's having trouble with that. If not, we're hoping that the team leader registered the facility and you downloaded the tracking tool to a computer. And here's always another challenge, and I'm very interested in hearing how people meet this one. In order to get Interact up and going, someone has to enter the data into the Safely Reduced Hospitalizations Tracking tool. So you're asked to do that last one to designate a person, or hopefully two people, or even maybe a department to own that process, and make that a firm decision. And then talk about how the data will be entered. Is it going to be daily? Is it going to be weekly? And then have the team track that tool together. So that was last month's homework, and that was a lot to take on. So I'd like to open up the discussion now. Is everyone able to get on the website? Have people been having problems? Because we do have the capacity to screen share with you. And Florence has, my colleague Florence, who unfortunately isn't here today, but she has some magic key that can unlock people's passwords. I don't know if she's hacking into it or what. But is anyone having problems getting onto the NHQI website?
Hi, it's Janice at the Lutheran Home.
Hi, Janice.
So, hey, I initially did have a problem, but I worked it out myself by just emailing the support at the website, and they ended up resetting the password because it was set for the former director of nursing and administrator several years ago. So that wasn't an issue. It was just about a 24-hour delay where I waited for their department to get back to me and reset the password. I since did find out through Florence that she could have done it. I did not know that at the time, but it wasn't a big issue for me just to email the site. I've had no issues. I did download it onto my desktop. I am the one that's entering the data right now and presenting that information on a daily basis. So I'm kind of just controlling it. I don't intend to be the only point person right now, but I just wanted to get myself familiar with the site, with the tool. I did invite Florence to come to Lutheran Home, but about a week and a half ago she came just to kind of go over everything, make sure that I was doing everything correctly, gave me some further insight into, filling out the tool. So it's been going, well. I do it on a daily basis.
Yeah, it's really good to have, one person who knows the process, but I'm with you on that, Janice. You don't really need to do it. I've actually seen facilities use, volunteers, because it's not that complex, the data entry piece. But somebody's got to own it. Somebody's got to crack it open, right?
Yeah, so right now I'm the owner of it as I get familiar with it, and then at some point I will be sharing and passing the baton, as they say, to somebody else in the facility. But I just felt at this point, as I get it up and running and get some data going, then I'll feel more comfortable passing it on.
Sure. Then you can become the subject matter expert. Anyone else have problems, or anyone else find it easy? The silence is hard to interpret. How about...
Looks like we have a question or a comment in chat from Zach Potter. I'm having issues keeping up with the data entry. We admitted with recent discharge tab alone with all of our turnover is very time consuming. I'm a few months behind, but catching up.
Wow. So Zach, how many readmissions or admissions do you average in a week?
Zach, if it's easier, you can press pound 6. Oh, 10. Okay.
All right.
Hi.
Hi, Zach.
Yes, I have about 10 a week.
Okay. And it's just,
I mean, we have kind of the old paper acute care transfer log. I'm not having a problem keeping up with the hospitalizations and all the information that goes with that. It's more just the, day to day, everyone coming and going. But I am catching up. I have everything in there. That data's just not accurate because I don't have the full population represented at this time.
Sure.
I have all the hospitalizations in there. It's just a matter of kind of catching up with all the admissions for everyone.
Right. So what you're saying, Zach, is the heaviest lift to this project is that initial data entry where you put all your residents in.
You got it.
That's the challenge. I hear you.
Yeah.
I hear you. And before you got the chance to get that done, they started coming in and out, right?
Yes, you got it. We got 4 coming in tonight. It's just,
Okay.
But yeah, hopefully, I'm hoping if I can catch up and I can maybe get 1 or 2 more people to help share the burden a little bit. So that's the plan.
Right. Zach, what is your role at your facility?
I'm ADNS.
Okay, so you've got a million other things to do as well.
Lots of things, yeah. I'm new to the position.
Handful.
Yeah.
I think that's always the challenge. You want to get it done, but, Janice was saying at some point we have to, it's data entry. You're obviously a clinician, you're a leader. This might not be the best use of your time. But I've heard other facilities say that same thing, that initial lift, that initial big data entry. Mm-hmm. How many beds do you have, Zach?
120.
Okay.
Yeah.
That's hefty enough.
Yeah.
For sure. Anyone else on the call meet that challenge in a certain way? Find somebody to do the data entry piece? I mean, I guess one of the most innovative things I once saw was, somebody had a volunteer, because of course everyone under the age of 20 can do these things in 10 minutes, and they did that in this one. But yeah, that's probably going to, once you get that done, Zach, I think that you'll see the light at the end of the tunnel. Do you feel like you have your administration support? Maybe that's a loaded question, but I mean, if you do, you might be able to ask them for a little help with this. So thanks for sharing that. And do reach out to us if there's any way we can help you. We're more than happy to do that. Okay, so we've heard a little bit about that, like, who do we assign to do this day by day? And again, having your leadership and medical director, and when folks say, we want you to do this, what goes along with that is that we're going to support you and give you some resources. So thank you for that, Zach. Anybody else having any problem with NA and HQI that they want to talk about? Okay, again, I would just encourage you, if you have a problem, if you want to reach out to us, please do. We can help you with screen sharing. I wish I had someone to help you with going out there and entering the data, but that might be something to think about. The summer and summer interns coming. So don't write us off for things like that either. Okay. So, homework again for this session. Prior to your next Interact team meeting, try to download the medication reconciliation tool from the NNHQI website. Make some copies of that tool for the team to review. If you're using something else, if you're using a different type of tool, maybe download that too and have copies to compare them. Which one would you prefer? And make sure that MedRec tool is on a facility computer on a shared drive for people to use. You want to review that medication reconciliation tool and discuss how and when the staff nurses, supervisors, leadership, medical directors, and others will be educated on the use of the tool and decide which unit will begin to use the MedRec tool. If you're using another tool and you want to stay with that, that's fine as well. But as Margie said, it's important that someone takes ownership of that process. And I think if you put 10 long-term care clinicians together in a room, each one of them will have an absolute horror story of a medication, adverse event that happened during care transition. It's so easy to occur, and, it takes some time and thought to prevent, but we've all been there. We've all, accepted orders from the hospital that were a little bit wonky, that didn't match what the patient went out on, duplicative orders, downright transcription errors, and everything in between. So think about that. Think about what process you have in place now and how it can be improved. Again, we'll send out that link, and I encourage you to have your staff take the medication reconciliation course online. We'll provide you with a certificate of completion. It's, great in-service hours that don't cost your facility anything, and that you in turn can use as a QA/QI project. You can use to prove that this is a safety initiative that you're involved in. Develop a timeline to define when the education will occur. If you're going to use the medication reconciliation tool, then you need to talk to your staff about that tool. Look at the process that they're using, if they're using another process, and consider whether or not you want to have them go through the formal program. And it's good to have a debrief by the team after you've started using the medication reconciliation tool. If you have it on a unit, that's fabulous. And if you do, have a huddle sometimes after, so people can tell you how that went, whether they found it difficult, whether they found it time-consuming, what worked about it, and what didn't. Okay, one more time. We've got just about 2 more minutes. Any questions? Okay, again, please feel free to reach out to us with questions, with comments, complaints, messages of hope, messages of despair. We'll take them all and we'll work on them together and continue this journey together. I thank you for your time, and I'm glad that you're with us.
Thanks, Sheila, and I just want to thank everyone for a great discussion today. I just have a few last-minute announcements before we end the call. When you close out of the webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we'd really appreciate it. If you don't have time to fill out the eval right now, or you're currently sharing the computer with someone else, you'll receive an email tomorrow morning with a link to the eval, as well as the link to the event page on our website, which is also in the chat section. The PowerPoint presentation is posted on our website, and within the next 2 business days, a recording and a transcript will also be added. Be on the lookout for emails about our next webinar in June on communication tools and the PDSA cycle. Just a quick note, please remember that you must register individually for each webinar. If you don't, then you won't get the day of details email that has the slides in advance. So again, every webinar that we have on the Interact series, you must register for it, and you will receive an email invite for that. Thanks again for attending, and I hope everyone has a great day.